Welcome, ladies and gentlemen, to the monothematic conference on nutrition and liver disease, which was held in Ljubljana the 25th and 26th of November 2016. It was a two-day meeting just about nutrition and liver disease with distinguished speakers and many highlights, and we would like to discuss with you now a few of the highlights that we listened to during this meeting. Before starting, I would like to introduce myself. My name is Stefan Bischoff. I'm a professor for medicine and I'm a gastroenterologist. I'm also in nutritional medicine. I'm the head of the Department of Nutritional Medicine at the University of Hohenheim in Stuttgart, Germany. And the co-organizer sits besides me.
Good evening. My name is Matthias Plaut. I'm also gastroenterologist, head of Department of Internal Medicine of Dessau Community Hospital. I'm professor of medicine, and I'm delighted to welcome you on this occasion. And Stefan, I think you start and give your impressions on this fantastic meeting.
The particular thing of that meeting is that for the first time EASL decided to put nutrition in liver disease into the focus. We had 6 sessions during this meeting. The first one was about biliary disease and cystic fibrosis. The second one was about Eiffelt and Penelt and other nutrition-induced liver complications. The third one was about alcoholic and non-alcoholic fatty liver disease. The fourth was about acute liver failure. The fifth about liver cirrhosis. The sixth about liver disease and surgery. In every case related to nutritional issues. I would like to start with a particular highlight, which was the session on alcoholic and non-alcoholic fatty liver disease. Here we heard about many new and old things, and we spoke about the metabolic syndrome, which is increasing because of the obesity epidemic. And this is one condition that leads to fatty liver disease, besides alcoholic liver disease, which is the other major reason for getting fatty liver disease. Even though these two disease entities have many things in common, there are also very interesting differences. For example, that the consumption of saturated fatty acid is probably harmful in patients with metabolic syndrome, whereas the consumption of these saturated fatty acids in alcoholic patients is even protective. There were some conflicting reports about the result of sugars, which might be due to the fact that not every sugar induces the same effects. Obviously, fructose is a particularly harmful sugar in the context of metabolic syndrome and non-alcoholic fatty liver disease, whereas other sugars are more relevant for weight gain, but not so much for metabolic liver disease. From Craig McLean, who came from the US, we learned that the protein intake, in particular in the patients with alcoholic fatty liver disease, is just not enough. The average protein intake in these patients is around 57 grams per day, and what would be needed would be 85 grams per day. In the Eiffelt patients, as I said already, the saturated fatty acid might be protective. The same is true for protein intake, which is low, as we said. And if one can manage to enhance that protein intake, it has also a protective effect for the prognosis of these patients. A particular issue was the lipotoxicity, which plays a central role in the pathogenesis of non-alcoholic fatty liver disease, and which might be also relevant in patients with alcoholic liver disease, even though these patients usually don't have an increased fat mass. They have the opposite, but also this small fat mass obviously is so metabolically active that it also can induce this type of lipotoxicity. In another talk from Professor Manz from Hanover, we learned that there are very interesting relations between viral hepatitis on the one side and metabolic liver disease on the other side. Patients suffering from hepatitis B virus infection show in 20% of the cases steatosis, whereas in patients with hepatitis C infection, it's even worse. Up to 90% of the patients suffer from steatosis. And also for alcohol, one can say that the combination of alcohol and infection with hepatitis C virus induces synergistic effect, resulting in a very high rate of steatosis. And it doesn't end with steatosis. It can develop to fibrosis, in particular to cirrhosis. And once you got into these stages, the likeliness of getting insulin resistance and finally diabetes is very high. And this brings us to the point that the new hepatitis C virus therapy we all heard about is a drug option that not only clears the virus infection, but also ameliorates and improves steatosis and insulin resistance in these patients. Last not least, we heard about the therapeutic options we have for the AFFLD and NAFLD patients. And in AFFLD, of course, it's abstinence from alcohol. But what else can we do? In NAFLD patients, we have the whole bunch of options related to lifestyle intervention, including dietetic approaches. And these include high protein, low sugar, low fat diets, probably supplemented with vitamin E, probably supplemented with fibers and prebiotics, a whole bunch of options. But finally, according to the big clinical trials we have so far, the long-term effectiveness is quite limited. Therefore, we speak now also about metabolic surgery. And indeed, surgery could show that it has a much more long-lasting effect. And the likeliness of getting rid of liver steatosis in the long term might be better after surgery compared to at least what we know for the moment after lifestyle intervention. These might be some highlights to the two disease entities, alcoholic liver disease and non-alcoholic fatty liver disease. And now I would like to hand over to Matthias Plaut.
Yeah, Stefan, I also, just like you, had the impression it was a very inspiring meeting, very interesting new data. And I was particularly fond of the session on nutritional management of the cirrhotic patient. And as hepatologists, we are all familiar with the child score. And in the original child score, malnutrition was one of the variables. But later on, this was omitted due to the problem which we all have to decide which patient actually is malnourished, or to assess the nutritional state of patients. Despite we all know, and we saw this during this meeting again, that the prognostic role of nutritional state and malnutrition is of extreme importance for chronic liver disease patients. Now we've moved a step forward since we identified that malnutrition covers a whole range of symptoms, and the hallmark of malnutrition is a loss of muscle mass. And this, we call it sarcopenia, now offers the option that we can have new tools to measure this loss of muscle mass, which might bring us in a situation that we can now much more clearly diagnose malnutrition. And so it's not only muscle mass, but it's also muscle function. But for instance, muscle mass, here we had the pioneer from New Zealand, Lindsay Plank, who showed us the data of the gold standard method to assess total body protein status in vivo neutron activation analysis. But in this case, this is available only for the selected few. What else can we do? We can use CT or MRI imaging and use tools to assess muscle mass by this means. And even in patients in whom we do not have this tool, we can use bioimpedance analysis and use the phase angle to precisely assess nutritional state. And here we have a parameter which is of prognostic value. So this improves the situation of identifying the patient in need for a nutritional intervention. On the other hand, we had great news of a very active group from Cleveland, Ohio. Dasarathi told us, he showed us his excellent findings in identifying the mechanisms involved in the pathogenesis of sarcopenia. And so now we can see that there might be approaches open by using this knowledge of the pathogenesis of sarcopenia, so we can target this pathway. But on the other hand, we know that patients suffering from malnutrition with cirrhosis, they just don't eat enough. And so our main goal is to supply adequate food. And by using this probably very simplistic approach, but it's effective, by this approach we can improve the metabolically relevant compartments in our body, body cell mass. We can improve total body protein status by making use of nocturnal feeding. So doing what normal people should not do because we get overweight, but the cirrhotic, malnourished patient should eat in the evening and at nighttime and to avoid long periods without food. We can improve that, and we know, and we could see that we can also give adequate amount of protein to the patient with encephalopathy. And here we have a common denominator, adequate amounts of protein, as Stefan just mentioned, in patients with steatohepatitis, alcoholic steatohepatitis. And we are happy to see that we are away from the older times when people restricted protein intake in patients with chronic liver disease. I think this was very clearly stated, and this should be a good motivation for all hepatologists to treat their patient adequately and provide adequate nutrition.
I think the protein issue is really a crucial issue. And we also discussed very interestingly what kind of proteins might be the right ones. Because on the one hand, we say, yes, we need more protein. But on the other hand, we say, don't eat too much red meat, don't drink too much milk. What would be the ideal protein source for this type of patients? Perhaps you would like to comment on that?
Well, we are happy to have these fundamental studies showing that adequate protein intake is necessary for these patients. Adequate meaning 1.2 to 1.5 in the cirrhotic patients. So far, we do not have any systematic evaluation on the protein source, but as an example, which we are confronted with in everyday clinical life is the situation when the patient with cirrhosis has upper gastrointestinal bleeding. So blood comes into the gastrointestinal tract. Blood is a protein source, but blood is a very special juice, or is thicker than water, but is a source of protein of very poor biological value because it has very low content of one particular amino acid, isoleucine, and this has been recognized. And this lack of isoleucine increases protein catabolism and thus makes patients more prone to develop an episode of encephalopathy. And so by just supplying this particular amino acid or the group of branched-chain amino acids, we can really intervene in this pathophysiological process. And this explains, from the hindsight, the beneficial effects observed by nutritional supplements containing branched-chain amino acids.
And it underscores that at least for this particular subset of the population suffering from liver disease, the vegan way of life is not a good idea.
Vegan diet is an extreme form of vegetable diet, and we know from older studies that a vegetable-based diet increases fecal nitrogen loss. So the body loses more nitrogen, and we should be aware of it. And if a patient follows a vegetarian diet, he should be sure to have an adequate protein intake to match the increased loss via the feces. Well, these were the big. So these were the big sessions, but we had some other sessions which were very interesting, just like the big sessions. And I don't know what your personal favorite is, but I very much like the lecture on the role of celiac disease in the occurrence of liver disease, because I have the impression that many hepatologists are not so aware of the celiac disease-induced celiac hepatitis, as Professor Volter puts the name for it. Actually, quite a number of patients with celiac disease develop enzyme abnormalities and mild elevation of transaminases, but they can even have more advanced or more severe liver disease, some even as severe as to being listed for transplantation. And some of them have been saved from transplantation because the diagnosis of celiac disease was made and gluten-free diet improved their liver function.
What's also interesting in this respect is that enhanced transaminases can lead to a false diagnosis, because you think perhaps of liver disease and you forget about the option that it can be also celiac disease. Therefore, there is some argument, in particular in patients who have elevated transaminases, to consider as one possible cause celiac disease and to screen in these patients.
And I think it's a very nice example of nature to demonstrate the very important and so by no means fully understood role of the gut-liver axis. There are so many interplays between these two organs, and in this situation one can say the liver is the victim of the sick gut, but there are many more interactions between these two organs.
This was actually also one of the highlights, that the gut-liver interaction, and we discussed this in particular in the context of non-alcoholic fatty liver disease, but also alcoholic fatty liver disease. In both cases, we have now very convincing data, both from animal experiments, but also from human experiments, showing that high sugar, high fat, Western style diet, in a similar way as alcohol does it, induces impaired gut barrier, with the result of translocation of bacteria, or at least bacterial products, further contributing, besides other mechanisms, to the so-called low-grade inflammation, which is considered to be one of the major causes for the malnutrition.
Yes, I found that very impressive. Herbert Tilk from Innsbruck put it that way, that he can even propose diets which are pro-inflammatory and diets which are anti-inflammatory with regard to the sequences you just mentioned, increased gut permeability and steatohepatitis.
So in future we will have not only diets that improve your personal feelings, that improve your personal relations, but also influence either in a positive or negative way inflammatory diseases. We also heard that in some cases there might be side effects related to nutritional therapy, in particular to parenteral nutrition. This was one of the issues in the earlier sessions we had during that meeting. I speak about Eiffelt and Penalt, and these conditions occur in particular in patients in which certain rules have been neglected that should be followed during parenteral nutrition. What was your feeling about these data?
Yes, I find this a very important issue because in these patients who need long-term parenteral nutrition, for instance, because they have lost a lot of their bowel due to infarction or some other reasons, there it is very difficult to dissect actually the separate roles of the gut disease or the missing gut on the one hand and the parenteral nutrition on the other hand, and to be really sure when there is liver disease, is it the consequence of the gut disease, or is it a consequence of the wrong handling of the parenteral nutrition? And this is very important because we very often, in the clinical situation, we have very often come in the situation that people are very ready to say, this is a side effect of parenteral nutrition, but it probably is the effect of the gut illness. And so we cannot take away parenteral nutrition from a patient with very severe short bowel syndrome who is dependent on parenteral nutrition. So we have to better tune parenteral nutrition to avoid these side effects.
Perhaps as a last point, I would like to emphasize that this monothematic conference in Ljubljana was not only about clinical issues. We learned also a lot about mechanisms. And as you have heard, one of the major mechanisms we are interested in is the mechanism of how we lose muscle mass. And there is now a really deep insight into the mechanism, how this works. And we had Dr. Dasarati from the United States, who offered us a deep insight into the molecular mechanisms. Therefore, I think this conference not only offers interesting information for the clinicians among us, but also for the basic scientists.
Yes, and I think this was a very eye-opening meeting because we come here as hepatologists, and I think many of us go away not just looking at the liver, but now realizing that other organs, and very often neglected organs like muscle or fat tissue, are of big importance in patients with liver disease. And so I would like to invite you all to, if you are now curious and to get more information on that, to go to the EASL liver tree, where you can see the presentations of this monothematic conference, you can see the video recordings of the lectures, and you can see many more interesting material on liver disease.